give it 2 more minutes. Oh, hello, everybody. My name's Hannah. We're going to give it 2 more minutes to just let some people still join, and then we're going to start at 2 minutes past the hour. So good morning, good afternoon, everybody. Thank you for joining our webinar today. We're going to be talking about the missing billion systems level assessment. We got 3 components to the webinar. First, there's going to be an overview given of the whole assessment. Then we're going to have the experiences shared by 2 different Ministries of Health. And then there's going to be an introduction of the new module on intellectual and developmental disabilities. This session is being recorded. There is also a channel, a translation channel. Constanza will be speaking in Spanish, and you can switch, make sure that you're in the English channel to be able to hear her translation. So, my name is Hannah Kuper, and I'm going to be presenting and chairing today. I'm one of the founders of the Missing Billion Initiative, and I'm also the co-director of the Disability Centre at the London School of Hygiene and Tropical Medicine. I'm going to be joined by Dr. Constanza Piriz Tapia, who's head of the Department of Rehabilitation and Disability at the Ministry of Health in Chile, and also Dr. Ahmed Osman, who's the senior advisor to the chairman of Department of Health in Abu Dhabi, and last but not least by Anjela Jenkins, who's the director for Global Inclusive Health Advocacy at the Special Olympics. There are other people who are online, so please do, excuse me, you can engage with people in the chat, and then there's going to be time for questions and answers at the end of the session. Excuse me. So first, I'm going to start by giving you a bit of an overview of the systems level assessment and the key components in its development. Sorry, I was like choking. Sorry. So just to set the background, which many of you will be very familiar with, people with disabilities are a very broad group. They include people who have long-term physical, mental, intellectual, or sensory impairments, which interaction with barriers can hinder their full and effective participation in society on an equal basis with others. And there's lots of excellent work looking at the situation of people with disabilities. And within the Missing Billion, we focused very much on access to health and health status. And we've produced 2 reports in 2019 and 2022 that highlight how people with disabilities are experiencing worse health than others across the Sustainable Development Goal targets. And as a result of these barriers, people with disabilities are experiencing worse health outcomes. So for instance, new data shows that their mortality rate is over 2 times higher, they're 3 times more likely to have diabetes, and twice as likely to have HIV. Now, with people with disabilities, we're talking about a really big population. So there are at least 1.3 billion people with disabilities in the world. So that's 16% of the global population. So if we have these inequities for people with disabilities, we will be failing to ensure their right to healthcare, but it also means that we'll be failing to reach targets like universal health coverage or the Sustainable Development Goals. So it's really important for us to start looking at health systems to see how better to include people with disabilities. The problem is that the issues seem really insurmountable, so it can be quite hard to know what the issue is or where to start. And so within the Missing Billion, we've started to try and think about this in a structured way. So we developed an assessment called the Systems Level Assessment, the SLA, which is a toolkit to evaluate the extent of disability inclusion in the health system. And the main purpose is to allow Ministries of Health to assess their health system and identify where changes are needed. So there's a really structured way to see what the issues are and therefore what kind of interventions are needed, rather than things being tried in an ad hoc way. I will go through this in more detail, but essentially the SLA includes a set of indicators, steps, and tools to be able to look at the health system to see where there's progress or where there's really good examples to share, and where the gaps remain, where there needs to be action. And if that SLA is repeated, then it allows Ministries of Health to monitor trends over time to see what's changing and also to see whether certain interventions may be impactful. And if we start using this tool or a tool consistently in different parts of the world, then we can start to highlight good practice examples from different settings that could be shared in different countries. The tool was really designed with the Ministry of Health in mind, so that the Ministry of Health can look at their own health system to look at disability inclusion, but it could also be used by disabilities rights groups to identify gaps and identify for change, or for researchers and as part of monitoring of disability inclusion programs. The SLA is one of 3 tools that the Missing Billion has developed to date to measure and improve health systems. So I'm just going to mention that quickly. So there's this systems level assessment, the SLA, and that assessment identifies opportunities to improve disability inclusivity at the health system level. There's the facility level assessment, which is an assessment that focuses on disability inclusion gaps within healthcare facilities, such as outpatient clinics and hospitals, and identifies areas for improvement. And because often the SLA has been showing that healthcare worker training is a clear need, we've also developed a healthcare worker training survey that can help to identify training needs of different cadres of healthcare workers in that country to help show what kind of training needs to be developed. So as I'd mentioned, there are 3 objectives to the system level assessment. The first is to look at the status quo, so to collate data about the health system to be able to set a benchmark for the disability inclusion in the health sector. The second is to identify where action is needed, so the ways in which the health system could be more inclusive of people with disabilities. And then the third, with repeated use, to monitor, so to continue to monitor progress over time using the same indicators. This tool has been quite a long time in development. So we started during the COVID years of 2020, where we looked at the existing frameworks to see what we could add to be complementary. And we focused in on 2, so the PHCPI, which looks at primary healthcare, and the Levesque framework, which looks at patient-centered care access to healthcare. We then developed a list of indicators, and we pilot tested these with research partners in the Maldives and Zimbabwe. We then, in 2022, worked with Scope Impact, which is a human-centered design company, to see how we can make this tool very usable and practical. And we consulted with an expert committee and had individual sessions with different Ministry of Health and their technical partners to further improve the tool and the approach. And then last year, in partnership with McKinsey, we did a rapid test in 10 different country states. So that was looking outside in, so it wasn't in collaboration with the Ministry of Health, but more to see what was feasible. And then working together with Ministry of Health in partnership, or their research institutions aligned with the Ministry of Health, we applied the tool in Brazil and Chile, and then finalized the tool looking at what happened from there. And we're now working for its on-the-ground implication of this finalized version in a country in the Middle East and in Mozambique, and we've got more plans to work with other partners. Just to quickly note about the committee, so we had this expert advisory committee that included a mix of health systems people and experts, and also people with disabilities, and also people from different parts of the world, including from the Global South, to see whether this was appropriate and usable. So I'm going to describe a little bit here. So we wanted to have a framework to provide a real structure for this assessment. And the framework that we developed is this Missing Billion Inclusive Health System framework. So when we think about improving health systems, we often think about that service delivery component. So we might think about the supply side, so it's things like human resources and health facilities, and making sure that there's rehabilitation services and AT, and also the demand side, so that's the people with disabilities, that they have the autonomy and awareness to be able to seek care when needed and can afford care. But these service delivery components of what we can see come from deeper underlying components of the health system, which we call the systems level assessment. So to have good, for instance, human resources in place who are well trained about disability, this relies on systems levels, things like having good governance. So that's laws and policies in place that protect the right to healthcare for people with disabilities, having leadership on disability within the Ministry of Health, having financing in place within the health system to support disability inclusion and reasonable accommodation, and that there's data and evidence to show both that this is an important issue, where the needs are, and what works. With our argument is that with these systems level components and the service delivery components, there'll be better outputs, so better coverage of services for people with disabilities, and ultimately better outcomes, so better health system. So across these 11 different components, we came up with a series of different indicators to see how well the health system is doing in these components. We consider the system and the service delivery components to be mandatory and scored, whereas the outputs and the outcomes are more optional. So it may only be available in some countries. These tools and these indicators were developed to be pragmatic. So we formulated indicators and tested them to make sure that that data was collectible and it was achievable. And this is what we pilot tested in the different countries that I mentioned. The overall process of conducting the SLA should take about 2 to 3 months, but this is going to vary from case to case. As I said, we developed the indicators to be from existing sources to make it as streamlined as possible. And we would hope very much that the SLA would be initiated by the Ministry of Health, but it could be initiated by other entities, in which case it might take a little bit longer, both to collect all of the information needed, but also to align with the Ministry of Health. In terms of process, there are kind of 4 key steps. So the first step is to identify the leadership and establish a task team. Then there's an inception meeting to agree the parameters and who does what. Then the assessment is conducted, and then there's a workshop at the end to share the results and for strategic planning. And I'll go through each in a bit of detail. And as I said, the assessment is according to the 3 components, so the systems level, the service delivery, and the outputs and outcomes, which can be optional. So how this works is I described the 11 different components of the health system. And for each of those components, there are a number of indicators. So if we look at governance, for the governance component, there's 6 different indicators. So the first is the ratification of the UNCRPD. The second is whether there's existence of national law protecting the right to health for people with disabilities. The third is the same, but for national policy. Then consideration of whether people with disabilities are included in national health sector plans, in national disease plans like HIV, and whether there's a cross-ministry task force or coordination structure to coordinate all the issues of disability. Then there's information required for each of those indicators. So it can just be yes, no. So for instance, for the ratification of the UNCRPD, that's just yes, no. But there can also be more information. And then there's a scoring. So for each indicator, it's scored 0 if it's not fulfilled at all. It's scored 1 if it's fully fulfilled. And for some of the indicators, there can be a scoring in the middle. And so that is then carried out across all of the indicators. I think there are about 50 or 60 in general, in total across all of the components. In terms of leadership, we think that, as I said, the assessment should be led by the Ministry of Health, who sets up a task team. It could also be by an NGO or an OPD in coordination with the Ministry of Health. There must be meaningful participation of people with disabilities in those teams in a non-tokenistic way, which means it must be ensured that all the processes and activities are inclusive and accessible. And the task team should have about 5 to 7 members, which includes, as I said, the Ministry of Health, people with disabilities and/or OPDs, and technical and NGO partners and donor representatives. So then you get all of this information across all these indicators, and then what do you do with it? And what I'm going to show in brief, and then the examples from Chile and Abu Dhabi will go through more in detail, is some kind of sample output. So here is one sample for a country. So you can see that the overall score for that country was 60%. But then you can look component by component. So for the system level, the light blue line is seeing how that country did across those 4 components. And the dark blue is the comparison of those 10 health systems that we looked at. And so what you can see, for instance, for system delivery is this country is doing well on health financing. It's scored a 1 overall. And so that's encouraging for the country that that's not an area where change is needed, but it also flags good practice for other countries. That shows that this country is doing something well where other countries are not, and maybe it can provide a partial solution. Whereas for this country, it is doing not as well in data and evidence and in leadership. So that might be areas for improvement, but also for learning from other countries. So things are scored as being low, intermediate, or advanced. And so you can look at it as a whole, or you can look at it by the different components, but it can also be by the different indicators to see which are the areas where there's a particular problem. So here, for instance, you can see that there's no formal representation of people with disabilities in task force. So that might be thinking, you can start thinking then about individual actions. So what will happen then is there'll often be a very long list of things to do, and that can be a very long laundry list, which means that things may not happen at all, and there needs to be a prioritization. And the prioritization can happen based on 2 different things. So first, how the score is. So if something scores very low, then obviously that's more likely to be something that you prioritize. But in the workshop where you come together at the end to consider these different factors, there's also consideration about where there can be the most feasible intervention to help prioritize action, and also where there's going to be the biggest impact. So in terms of things like impact, you can think about things that are foundationally important to create an environment where disability inclusion is on the agenda, where there's a change opportunity, for instance, that there's a new government or policy, the number of people with disabilities affected, the time taken to impact, and the strength of the evidence. And in terms of feasibility, things like how long it's going to take, how much cost, how complex, both in terms of stakeholder complexity and technical complexity. So once there's this idea about what the big priorities are from the scoring, you can start mapping them out by impact and feasibility to see what will be quick wins, big shifts, low effort gains, and incremental improvements. So obviously you would then start thinking about starting with the quick wins. So as an example, from the country that we have looked at, the kinds of quick wins could be in leadership, having formal representation of people with disabilities in health sector coordination. With data and evidence, maybe there's already evidence, but it needs to be analysed and published and then used to inform programmes. There could be development of a national health sector plan and national disease plans, or review of public transport links for facilities. This has been very, very whirlwind, and I've been trying to go fast because there are other speakers who will present great data. But if you do want to find out more, all of the information, including, I think this presentation is going to be on our website. So the documents are on the website. You can reach out to us to ask for working templates. There's the publication has been deposited about the process of developing and piloting the tool, and the ones for Brazil and Chile are going to be in submission soon, so you can contact us for copy. So that was very much the overview, the whirlwind overview of the systems level assessment. And now I'm going to turn to the partners from Chile and the Middle East to share some of these experiences by the Ministry of Health. So the first speaker is Dr. Constanza from Chile. As I've mentioned, she's going to be speaking in Spanish and there's going to be a translation. So make sure that you have your Zoom setting to be in the English version. I think there's a button at the bottom. And Dr. Constanza, please tell me when you need me to go to the next slide.
Okay. Muy buenos días.
Good morning. Good afternoon, everyone. Thank you very much for the invitation to be able to present our experience with the application of this assessment in the country, together with your support, with Ana de Rodriguez support, among others. I'm going to talk about our experience in terms of this assessment. Next slide, please. Well, we're talking about a country in South America with almost 20 million inhabitants. We have 18% of the population with disabilities, according to the latest national study carried out in 2022. We're still working on these results, looking into them in depth to be able to have a thorough vision of the situation of disability in the country. In 2008, Chile ratified the UN Convention on the Rights of Persons with Disabilities, and since 2010, we have a specific law with regard to the rights of people with disabilities in the country. This legal framework has led to important changes in terms of accessibility, responses in terms of people with disabilities needs. There's still a lot to do in different areas, not only with regard to healthcare, also with regard to transportation, housing, social matters, and also with regard to the social dimension of healthcare that leads to an improvement so that people with disabilities have a better health, taking into account the prevention measures that can be implemented. When we started working on this process, we were invited to be part of this research group in 2022 with a doctoral research project. The work to be carried out is proposed. We define a specific tool with regard to the research. We plan the whole process, identifying the different stakeholders that would be participating from the public sector, the private sector, and also people with disabilities and other organizations that could also help us review the evidence, the statistics, the whole process with regard to the governmental reporting. All the needs that had to be planned out, specifically with regard to gathering the information. Also, on the other hand, we launched awareness-raising activities with regard to social organizations, and this is one of our reflections as a Ministry of Health that has to do with we couldn't actively work with social organizations. This meant that we had to be more open to this as an institution. It is a political definition of the Ministry of Health with regard to collaborating actively with social organizations. And this, well, meant a more open-minded attitude with regard to personnel, and also taking into account that social organizations had to make their requests according to our requirements, not all at the same time as an avalanche, but more according to our requirements. We carried out an assessment process with the interviews, the work. We organized a workshop in different sessions because we work with social organizations from different parts of the country, and therefore we needed to take into account the territorial diversity, and maybe this led to longer timings. And then we also had a final dissemination and final presentation of the process with different stakeholders, and we set the foundations with regard to the results that were going to be obtained and also the future planning in terms of future years. Next, please. We have collaborated with the London School of Hygiene and Tropical Medicine, with Lupus Chile, with different organizations, fibromyalgia, with an organization focused on psychosocial disabilities, with the OPD Foundation, Independent Living, with an NGO that focuses on people with visual disabilities and deaf-blindness, rare diseases, a patient organization, and also an NGO that collaborates and helps, supports different populations with different types of disabilities. All of this, these members were led by the Ministry of Health. Next one, please. This was the objective of the study: to evaluate the inclusion of people with disabilities in the Chilean health system and define evidence-based recommendations. All the different studies carried out and proposed by the World Health Organization and other organizations establish the importance of the inclusion principle and also the evidence-based approach. We needed to generate improvements in the system and in the services. And this is why we needed to identify the barriers within the healthcare system and also taking into account the existing situation. And we achieved 49% score. This score changed slightly because we fine-tuned the study according to the indicators. Indicators are set for standard use. Certain theme lines did not fit in exactly with our healthcare system, but we tried to have an inclusive, thorough evidence gathering. For us, 49%, taking into account the expectations that we had, is quite low. But the important element was to really reach a final result with regard to how our healthcare system is responding to the people with disabilities needs. And in this regard, we had to take into account the complexity of the situation of the system with regard to the healthcare needs of this population. We managed to be
Sorry, I'm just going
coherent,
to, so you've just got
consistent.
2 minutes, so if you can move to the next, that would be wonderful. We need
¿Eso qué
to move.
a la próxima?
Yes, next one.
Ah, perfecto. Sí. Muy, ya. Vamos terminando.
Okay.
Entonces, en ese análisis que se hizo,
Within this assessment, we achieved an important percentage in terms of governance, data and evidence, and the health financing. We have a universal system. Leadership was taken into account, but the score was lower. and it is not as present in the services provided. Next one, please. This has to do with the service delivery findings. We managed to have a good level of accessibility. Rehabilitation has been improved in the last years, and it's got a good acceptance in terms of the social elements. In terms of autonomy and awareness, there's a gap, and also with regard to affordability. This is an important focus that we need to develop together with social organizations so that this can be improved. Human resources, as we consider that we focus on medicine and nursery, they don't have specific training in disabilities. We do have other healthcare professions that do have a training that includes people with disabilities, but in terms of medicine and nursery, it is not up to standard. Next one, please. One of the priority actions that we're going to carry out.
Is it possible to wrap up now? Because we need to go to the next speaker. So if she can finish the next slides really quickly, please.
Ni un problema. Sí, las tres prioridades son
Three priorities: national inclusive health policy for people with disabilities, ongoing training for healthcare teams, number 2, and 3, leadership of social organizations with regard to disabilities. These are the 3 priorities. The first one will be carried out this year, and the other 2 in 2024, 2025. Okay. Well, these are the key lessons: to work with people with disabilities, to acknowledge that the systems, even if they are universal, they have to be observed in detail in terms of accessibility, and also it is relevant to identify barriers to the needs at the local level. Thank you very much for your attention.
Thank you so much, Dr. Constanza, for the presentation. I'm now going to hand over to Dr. Ahmed Osman, who's going to present from the findings from Abu Dhabi. You're on mute, Ahmed. You're still on mute. You're still on mute. Yeah, I think you're unmuted now. No. You're still mute.
Okay.
Yay. Over to you.
Okay, thanks a lot for that introduction, and pleasure to be here with everyone today. So my name is Ahmed. I'm an advisor at the Department of Health here in Abu Dhabi. We've been working with the Missing Billion team over the last 6 months or so. Now, beyond health, but also inclusive of health, Abu Dhabi has set a vision for people of determination. There is a clearly outlined strategy with a vision to be an inclusive and empowering community for what we call people of determination in the context of the UAE. That's the term that they use here. The mission in particular is, as far as DOH is concerned, cascading down from that vision, is to ensure that people who have disabilities in their families through an integrated system are able to access high quality healthcare services, ensuring a full contribution to society, cutting across public and third sector and private sector as well. An example of that commitment is obviously hosting the World Federation of the Deaf Conference for the first time in the Middle East region. If we move to the next page, what we have done in collaboration with the Missing Billion is 2 things. We've rolled out the system level assessment, which is a focus of what I'll cover in the coming pages. We have also done the facility level assessment, piloted across 2 healthcare facilities, outpatient focused, at different sort of states of modern development. And that also went very well. I won't focus on that today, but I will mention it a little bit later as we're looking to integrate that into how we assess providers across the system. We move to the next page. Our overall system level output score came out at 60%. From a system delivery perspective, a key strength was health system financing, with relative strengths in governance. But the two clear areas of opportunity were data and evidence and leadership. What's interesting is Abu Dhabi actually has a fantastic data infrastructure. So every single activity in the healthcare sector is tracked. Every patient has one unique ID. So it's a strong base on which to actually start building the ability to collect, analyze, and publish data around disabilities through this unified health system. So whilst it's weak today, the infrastructure really is quite strong. So we're really hoping to move that index up very quickly over the coming years. Another component was leadership. That was also kind of indicated, as we find out in a lot of our interviews with stakeholders, as well as people as OPDs, is a lack of formal representation across different forums in the health sector teams, and also a lot of the government entities and semi-government entities that are driving health sector strategy and reform. When it came to service delivery, what we found was autonomy and awareness, and HR had the greatest rooms for improvement. And I'll discuss a little bit of some of the opportunities that we identified around that in the coming pages. But overall, the view was encouraging. And what was great about this output was that it allowed us kind of give an X-ray of the system, knowing that this was anchored on best practice. So the gaps that came up were really the areas that we knew we needed to double down on, and we were able to prioritize where we invested our energy. If we move to the next page. As part of this process, we also engaged OPDs very actively. And what was great for us was that we did this in parallel to actually running the survey. And what it did was kind of reaffirm some of the areas of opportunity that the survey was clearly highlighting. Healthcare worker training, we'll double click on very shortly, but was clearly an area where we needed to invest to actually create trainings and awareness that were tailored to the regional context, that would support patient-facing staff in a way that was kind of unique to the culture of our region. Mobility is a real issue in Abu Dhabi, that last mile in particular. So reducing waiting times and distance between bus stops to actually allow for dedicated seating arrangements, and also ensure that patients were able to access the key facilities through shuttle access was a clear area of opportunity. And this was a really strong pain point for families as well, in particular. A few other opportunities, and I won't run through them all, but a unified health booking system that is accessible, reinforcing proactive follow-up and referrals for people with disability. What we find actually, as I've learned during my time here at the Department of Health, is that it's typically the second and third appointments where patients drop off, right? So the first appointment we do pretty well at. Beyond that, follow-up, particularly in the context of families with a large number of informal carers or formal carers that are employed by the local families, that then leads to issues in terms of continuity of care and comprehensive case management. And then a number of elements came out in terms of opportunities that were reinforced also through the facility level assessments we did, in parallel with that is ensuring calming environments that will dictate the patient's journey through a facility. So this was just to say that, we also did verify a lot of the findings, and the assessment tool came out as very accurate. If we move to the next page. I mentioned healthcare worker training. We ran a survey of healthcare workers in Abu Dhabi in parallel to running the survey. And what we found was that about a third of healthcare workers did not feel confident in serving people with disabilities. Only 40% had received any form of training. 80% had a desire to actually have more training. And less than half of them felt that had actually received the training in the last year. So not really up to date. A lot of them were eager for more, and a lot of them felt that they were actually relatively uncomfortable, right? Which I think is not potentially shocking to this group, given they were quite well versed in this area. But that fact perked up a lot of interest across the department. Not only it's about access, but also the quality of the training content, right? So the trainings that they are receiving, less than 10% of them ranked it as actually useful. So a real focus for us is how can we collaborate with other parties to ensure that we're doing this in the most effective way that will actually lead to end user impact. If we move to the next page. The SLA results, as I mentioned, right, these were kind of the 4 areas, and with some example interventions. I think I mentioned a few of these already. Analyzing and publishing data sets in particular is an area of focus for us, given that we see that as a key strength that we want, a spike that we kind of want to build on, and actually integrating the evidence base from that data that we collect to generate insights that actually ultimately inform decision making. We kind of frame that here in the department as intelligence, and this is one of the areas of intelligence that we want to build out. We've now started to roll out registries. So a disability registry is very much a key part of the agenda, and how can we tag people with disability against their unique indicators. So I think we just moved back 1 page, and all of this combined will be part of our integrated strategy that we continue to refresh. And ultimately the governance for that is key, and a key part of that governance is going to be leadership representation for people with disabilities across the different levels and committees that define our sector. Now, the facility level assessment I had mentioned earlier, we run that as a pilot across 2. This aligned very much with the insights that we saw at a sector level, but actually gave actionable plans for each of the facilities to be able to roll out. Now, for us, what's exciting is the ability to integrate this into our assessment and auditing of healthcare facilities. We hope to move to a model whereby we have a STAR system already across the different parameters of quality for a healthcare provider. Disability, health inclusiveness is another area that we want to add, and to actually incentivize, whether that's through financing or through diverting of volumes to centers that demonstrate excellence in care for people with disabilities. And we hope that market forces will actually lead to this being able to scale very quickly in collaboration with the Missing Billion team over the coming year. I think that's my last slide, so I'll pause here.
Thank you very much. And now we're going to hand over to the last speaker, who's Anjela, who's going to be presenting on the Special Olympics work and how this has been adapted to the situation of people with intellectual and developmental disabilities.
Thanks a lot, Hannah, and good morning, afternoon, and evening to everyone. I'm really honored to be part of such a distinguished panel to share about Special Olympics work with Missing Billion and around the SLA. So first of all, when we saw Missing Billion system level assessment, when it was first released, we were so excited. Special Olympics has been working on inclusion with a focus on those with intellectual and developmental disabilities, IDD for short, for over 50 years. One of the hashtags of our movement is choose to include. But we recognize, and Hannah pointed to this earlier, that turning the values of inclusion into action is not always so straightforward, especially in complex and resource-stretched settings like health systems. We saw Missing Billion system-level assessment is making disability inclusion in health systems a much more straightforward prospect. And we were eager to bring, or to help others bring, a similar level of clarity to IDD inclusion more specifically. That's how the idea for the IDD module was born. The module itself followed after around half a year of extensive desk research and key informant interviews led by the Missing Billion team, with at least 18 experts from over 7 countries. The IDD module, as has, I think, been insinuated by Hannah earlier, is a great complement for those who are conducting the overall systems level assessment, like the folks we just heard from. It can help them get a specific picture of what people with IDD face in their health systems. However, it can also be a standalone for a snapshot of IDD inclusion, which is what we at Special Olympics are doing. And I'll say more about that later. Next slide, please. Our motivation to develop this module with Missing Billion was threefold. As I mentioned, the mission of Special Olympics relates to the inclusion of those with intellectual and developmental disabilities. Scientific literature shows that people with IDD have significantly worse health outcomes than the general population, much like Hannah pointed to earlier for the broader disability population. The WHO highlighted this reality in the 2022 report on health equity for persons with disabilities, where they said, quote, a 6-fold discrepancy in deaths amenable to quality health care can be seen between persons with intellectual disabilities and the general population. And COVID has shown a particularly bright light on these health inequities over the past several years. People with intellectual and developmental disabilities benefit from a lot of the same adjustments to services that benefit people with other disabilities. However, they may have unique needs, some of which, if acted on, could also improve access for other populations. The middle image on this slide shows a young man completing an eye exam using a chart that uses shapes, rather than the one with numbers and letters that many of us may be familiar with. You may be able to imagine how using a chart like this could help not just those with IDD, but anyone who may have a hard time with number and letter concepts. That includes older adults experiencing cognitive decline, or those who don't speak fluently the language in the country where they're getting their health services. Finally, our reason, our why, is that Special Olympics is creating a world where people with IDD have every opportunity to be healthy. And we're doing this through what we call our path to health equity for people with IDD, which stands for prevention, assessments, training, and health system strengthening. Our work with Missing Billion on the IDD module is part of the health system strengthening part of our path. Next slide, please. An optimal use case for the IDD module is to have champions like Dr. Piriz Tapia, the next slide is good, from Chile, and Dr. Osman from Abu Dhabi take these assessments up and forward as a government-led initiative. But non-state actors, including civil society and academia, can have an important role to play in making sure that governments fulfill their commitments, like those related to the Convention on the Rights of Persons with Disabilities, like Hannah referenced earlier. And health practitioner advocates can be great leaders and allies of this work, regardless of where they sit in the health system or in academia. Next slide, please. The IDD module follows the same structure as the overall systems level assessment in terms of including the 11 components that were mentioned earlier and are pictured on this slide. Next slide, please. In most instances, the indicators are very similar, and the text is very hard to read, but in some instances, we replaced references to persons with disabilities with references to persons with intellectual or developmental disabilities. And the examples in 1.2 and 1.3 on this slide show that. In some instances, we're looking for maybe if the policy or whatever is in question, maybe has a specific reference that's additional to people with intellectual disabilities. So this sometimes shows up in the scoring methodology within this module. Next slide. But in other instances, we introduced completely new indicators to reflect the unique needs of the population with IDD vis-a-vis the population with any other kind of disability or all disabilities together. And this slide sums up the largest areas where we made those changes. Firstly, in some jurisdictions, people with intellectual and developmental disabilities are automatically stripped of their legal ability to make decisions for themselves on account of their disability. In some jurisdictions, there's a legal process required to achieve the same outcome. And in some jurisdictions, the substitution of the wishes of an individual with IDD by the decisions of someone else occurs as a matter of practice, regardless of whether or not the law actually allows it. This is, of course, a human rights issue. And so we included some indicators on this because we want to understand what laws and policies are in place on legal capacity and decision-making for people with IDD, including those which may go in the more favorable direction, rights forward, towards ensuring informed consent and supported decision-making. Secondly, while implementation often falls short, there tend to be policies and awareness that address accessibility and accommodations for people with motor, hearing, and vision impairments to at least some degree. However, accessibility and accommodations for people with IDD are rarely touched on. These may include longer appointment times, quiet waiting spaces, or calming environments, as Dr. Osman referenced, support for informed decision-making, as mentioned in the first block, and measures to ensure that caregivers can be appropriately involved in supporting care. A third area where we introduced indicators was around an emerging or established practice in some countries to use coordinators or other support staff to help people with IDD and caregivers navigate and coordinate health services. Often, these individuals are not medical professionals. But this role can be especially useful for those with complex care needs to ensure visibility and coordination across a number of different service providers. It can also contribute to continuity of care for those whose medical complexity and/or IDD can make it hard to provide a complete, accurate medical history to new providers. Finally, in terms of the areas that we added, it's been well documented in the scientific literature that early intervention helps optimize child development and health and education outcomes throughout the lifespan. Early intervention is unlikely to happen without early childhood screening, which is why we added this to the IDD module. Next slide. We at Special Olympics are really excited to be applying the IDD module in 8 countries and 3 US states during the course of 2024 as part of a newly launched project called Rosemary Collaboratory. Local consultants engaged by Special Olympics will be conducting these assessments in close collaboration with Special Olympics at the local, national, and international levels. This work is already rolling out with different types of responses and engagement by government actors. We're eager to see the findings later this year, and we're hopeful about responses to any identified gaps and good practices that we identify through the process. If you're interested in having a closer look at the IDD module or applying it in your country or jurisdiction, please also feel free to reach out. And I think Phyllis already dropped the links and contact information into the chat. With thanks to Missing Billion for the partnership and to all of you for your interest and attention today, I'll hand it back to Hannah. Thank you.
Thank you. Thank you so much to Anjela and all the speakers. So as she's mentioned, there are some links to contact and we've put that in the chat. And as already said, we do have information about the resources. We know that we've given you lots and lots of information, but things are online and we're always happy and ready to chat. And with that, we have a little bit of time for Q&A. So please, can you put your questions in the chat if you have questions for any particular ones of the speakers. We have a few minutes coming up, and I'm going to start by asking a question for Anjela, which is that how do you see there's clearly people with intellectual and developmental disabilities maybe the most left behind, and how can you put in a feedback link between the assessments that are happening for disability overall and IDD so that they're kind of joint and answering questions together?
That's a really interesting question. So, I mean, I think this is something that we're trying to do. There are some countries, or at least one we know of, where the broader SLA and the IDD module are going to be implemented at the same time. And so really making sure that there's that cross back and forth with the government, who, like the colleagues on the panel today, are leading those assessments, and the one that we're leading, so that kind of we're able to see, oh yeah, the gap is big here and it maybe is even bigger here, or there's a really good practice that we might have for the broader disability population, and how might it need to be tweaked to also make sure that people with IDD aren't left behind. So I think those are some of the ways that we hope to see the crossover happen, and that when the kind of standard or the ball is moving forward, we love sports metaphors at Special Olympics, for the general disability population, that we're making sure that it's also moving forward for people with IDD.
Okay, fantastic. And I know that, Dr. Ahmed, you've got to go in a minute. So I just wondered, what are your key lessons learned for other ministries who may be online or listening later in terms of doing this assessment?
Look, I think this assessment really is a no regret, right? That's the first thing. It provides a very quick X-ray view of where you should prioritize and focus. And I think one of the key things for a lot of ministries at the moment is competing priorities. I think as a starting point, this allows you to be very targeted in where you focus and also understand where your strengths are. And for me, one of the key learnings is doubling down on strengths is as useful, right, as trying to close some of the gaps that you have at a system level in particular, because I think closing the gaps takes more effort. So I think that prioritization and the fact that this is a repository of all the best practices really saves ministries a lot of time. And for us, this has been an opportunity to integrate this amazing work into what we do and how we hopefully assess facilities going forward, of very little energy that's required as an investment upfront. So would highly recommend this, and more than happy to discuss offline or in parallel to this with any other participants that would like to learn a bit more.
Thank you. And then Dr. Constanza, you presented, thank you for presenting the information of Chile. And as you said, some of the results weren't quite what you were hoping to be. You were hoping to score higher. And how did that go? Did that create sensitivities, or did this galvanize for action? What was the sense within the ministry with these results.
Efectivamente, las expectativas
Yes,
no eran
you're right. Expectations were not met.
como el sistema sanitario es universal, por lo tanto,
Healthcare system is universal. This is the narrative. It includes everyone, but especially with regard to people with disabilities, we are facing strong inequalities. This study also shows that healthcare services are the second most important barrier for people with disabilities. So this, for those of us who work within this field, it didn't surprise us as much, but it did surprise people who take decisions. So those who take decisions when it comes to institutions, political processes, they really are now eager to make this change and also to allocate more budget with regard to the needs of this population. And also the territorial emphasis is very important because we have different territories, different regions, we have different barriers in different areas, and maybe we have 3 or 4 that might be shared by all these territories, but also we need to identify in detail the gaps in each territory. And this will allow us also be closer to healthcare systems and healthcare decision makers in the different territories in collaboration with social associations that also support us in our work in the different territories.
Okay, thank you so much. I have another question for you because I know Dr. Ahmed is gone, which is who was responsible for administering the tools, who did the systems level assessment in Chile? So I believe it was coordinated between the Ministry of Health and Denai Rodriguez. So it was a collaboration, as I understand. Yeah.
efectivamente.
Yes, that's right. Denai Rodriguez sent out an invitation for us to participate as a ministry. We decided that it was necessary to carry out this study based on evidence, and I am leading the Department of Rehabilitation and Disability, and we focus on this matter within the ministry. There's also an awareness with regard to the ministry at ministry level, because we are defining the governmental programs that has to do with the system of care. And one of the objective population, the target population, sorry, is people with disabilities. And right now we are designing different public policies with regard to the system of care.
Yeah, so that was a really wonderful outcome from the assessment, that I believe that there's going to be new policies that are designed based on the assessment. So that was a really great achievement. So with that, I'm going to thank all the speakers one more time. So Dr. Constanza from the Ministry of Health in Chile, Dr. Ahmed from the Department of Health in Abu Dhabi, Anjela from the Special Olympics. Thank you all so much for joining. We are available if anybody wants any more information. Everything is online, but do be in touch, and anybody who uses it and has experience, please, we'd love to hear how it goes. So thank you very much and have a good rest of the day.